overview of papillomatosis, and then hopefully there'll be some time for questions. So the first topic is that of juvenile onset recurrent respiratory papillomatosis. Let's see if I can get my presentation to go. Right, if we look at definition, so juvenile onset RRP is defined as onset before the age of 12 years. So that's anything from 0 to 12 years, and adult onset will be classified as patients presenting after the age of 12. So I'll be focusing on the under 12 presentation. So as a background, RRP is the most common benign tumor of larynx in children. It's the second most common cause of childhood hoarseness after squamous nodules, so it always should be in the back of your mind, and that's also why it's such an important exam topic. The incidence is 4.3 per 100,000 and slightly lower at 1.8 in adults. If we look at HPV in itself, it is a DNA virus. There are currently around 200 subtypes identified, and that's quite interesting. It might show my age, but I looked back at a presentation that I did as a registrar, and in my presentation there, it said that there were 76 subtypes identified. So we've moved well past that, on 200 now. The four relevant subtypes within ENT is that of 6 and 11, and they account for 90% of laryngeal papillomatosis. And 16 and 18 are the other two, and they're much less at 10%. The relevance of the subtyping is that you can discuss with patients that if it's subtype 11, they're likely to have more aggressive disease, and if it's subtype 16 or 18, there is a higher chance of malignant transformation potential. And overall, the risk in children of malignant transformation is at around 1 to 2%. Onset before the age of 3, a slightly more aggressive disease. So if its onset is under 3, there's a higher chance of dissemination or distal spread, and also a higher chance of malignant transformation. If we look at the transmission, we know that it's vertically transmitted from at birth from an HPV infected mother. We know that 12% of cases will have transplacental transmission of HPV to the fetus. If in the presence of anogenital papilloma, the risk of developing RRP increased 231 times. And we know that if you analyze nasopharyngeal secretions in these babies, then 47% of them will have HPV present in their secretions. We also know that cesarean section is not protective. It does offer some protection, as we know that if there's an increase or increased delivery time, more than 10 hours, is a twofold increase in contracting RRP, and slightly higher chance in prima gravida, which is probably because of the prolonged birth usually associated with first-time mothers. So how do these patients present in pediatrics? We classify them as early or late presentation. So the early presentation are the ones where the disease is isolated to the anterior commissure or the free edge of the vocal cord. So they will present with progressive dysphonia. And the late presentations will be the supraglottic and subglottic disease. Now, thankfully, most patients will have disease at the free edge of the glottis, so they present slightly earlier. And the reason the supraglottic and subglottic present late is that we know that patients can have a reduction of up to 75% of their airway before they will show mild symptoms with regards to stridor. So they can have papilloma growing away without us knowing. If it's not affecting their voice, then they'll present late. So from a practical approach, because we all see pediatric patients in clinic, and hoarseness is not an uncommon presentation. So we know that it's common. They can be a difficult patient group to perform flexible nasal endoscopy in clinic. So as a rule, if there's worsening hoarseness or any stridor associated with hoarseness, the patients will, if they can't undergo an outpatient flexible scope, will qualify for a GA scope. So we'll always try, just from for practicalities and for ease and access, we'll always try to do flexible endoscopy. And we usually manage in babies under the age of 1 because they can be swaddled and held on the mom's lap. The reason I've said held on a parent's lap is I've been involved in one case where a patient presented within a week after having had flexible nasal endoscopy in clinic, presented to A&E with a non-accidental injury, and the procedure was blamed on, or the fractures were blamed on the ENT colleague that performed a flexible scope and had a nurse hold the patient. So it's always better to get the parents to agree and then for them to hold the child. If they're over a year, older than a year, I will always discuss and explain to the parents and say we can do it in clinic if they agree. It will be a bit traumatic for the child. And if the parents agree, then you can allow them, or usually manage to get quite far with bribery, and depending on the age group, it's either stickers, bubbles, sweets, and the ultimate bribery tool will be McDonald's. We've managed to get most patients scoped if there's a promise of a happy meal at the end of the clinic. So just to remind you what a normal diagnostic MLB will look like. So we assess the whole airway. We do photos of the supraglottis, the glottis, the subglottis, going down to the carina, usually try and get a glimpse down the right and the left main bronchus, and then coming out, examine the posterior wall of the trachea to see if there's any tracheoesophageal fistula. We assess vocal fold movement, which you can see clearly here. And then there are 2 more things that we need to assess, and that will be to assess the patient for the presence of a laryngeal cleft, in which case we put a probe in, go down to the level of the vocal cords, push back and see if there's a ridge that prevents the probe from falling in. And then we test for cricoretinoid joint fixation, which we're doing in this case. So moving on to treatment, the mainstay of treatment for the pediatric group will be surgical treatment, and we'll divide it up between laryngeal papilloma and tracheal or distal papilloma. We'll also briefly look at medical treatment, and we'll look at prevention. So surgical treatment, the mainstay will be debulking to maintain the airway and to improve the voice. And we know that we can't cure this patient with surgery. We know that if we biopsy the normal looking mucosa around within the larynx, that they'll find evidence of HPV within the DNA. I prefer personally to use a microdebrider. Some of my colleagues prefer to use coblation. The issues you can have with coblation is if the patient's not paralyzed, which they're usually not, it can stimulate and allow the vocal cords to jump, which means that you can cause inadvertent injury to the cords. The other issue as well is you rely on saline flush to create the plasma for the coblation, and that will essentially run down the airway. So in these cases, you have to have them in a head down position to enable you to prevent some of the saline running down the airway. A laser is becoming less popular because of collateral damage caused, but also because of HPV included in the vapor, which can put theatre workers at risk. This is a short video on just to show how we tend to use microdebriders. So we put it on a very low rotation, about 300 revs per minute, with suction fairly high. And what you try and do is to tease these pedunculated papillomas either out of the ventricle or off the vocal cord. And as you engage them into the microdebrider blade, press the pedal gently, briefly, and just to nibble bits of it away. We try and avoid the anterior commissaire, and if we're going to clear the vocal cord on within the anterior commissaire, we clear it on one side only and leave the other side unaffected, so that you avoid web and scarring formation. And what we want to achieve is essentially give the papilloma a haircut and wait for it to hopefully will go into remission when they're a bit older. So what we hope to end up with is pre-op picture on the left and a post-op picture on the right, which shows that we've managed to clear the pedunculated, majority of the pedunculated mucosa, but there's still some sessile papilloma left on the posterior third of the right vocal cord there. How do we deal with tracheal disease? Now, thankfully, this is quite rare. When we're going to examine a patient, or when we do debulking, we always examine the distal trachea and the carina, the left and right main bronchus, to make sure that there's no evidence of distal disease. This is a patient that I treated for a while, who unfortunately passed away. And this was papilloma that spread down the trachea. He always had a little bit of tracheal disease, but also pulmonary disease. And when he eventually developed cancer, squamous cell carcinoma, and he was on chemotherapy, the papilloma just took over down his trachea. So distal tracheal disease, we try and remove either by debulking, or this is where we tend to use laser. For debulking, we use a ventilating bronchoscope, as demonstrated on this picture, and then you either use a flexible forceps or sidearm forceps, which you can pass through the sidearm port for the ventilating bronchoscope, and that's usually where we will pass a suction catheter down. So this is thin enough to go down and extend past the distal end of the bronchoscope, and will allow us to pick little bits of papilloma off in the distal trachea. There's also another instrument that the pediatric surgeons use for laparoscopic surgery, which is a more flexible and malleable forceps, which you can also use. We tend to use laser in the really difficult ones where we can't get the bronchoscope tipped far enough down, and we can't get the sidearm forceps to engage the papilloma, in which case we can introduce a laser fiber via the suction port, and we usually use a KTP laser, so a beamed laser, where we can actually we're not necessary to make contact with the papilloma, but we can ablate it with KTP. It's quite tricky, and you need a very calm anaesthetist when you do this, because you're working way down the trachea, way down the airway. Oxygen should be really low down or switched off, and there's no way to protect the airway that far down with packing and patties, so it is quite stressful for everyone. With regards to tracheostomy, we try and avoid a tracheostomy at all costs, and that's because of the risk of tracheobronchial spread. Now, we're not sure if a tracheostomy increases the risk of tracheobronchial spread, or are these the group of patients that are severe enough that when they require tracheostomy, that they'll have disease that would have spread down the tracheobronchial tree in any case. It tends to be required in about 14% of patients, probably less now with the techniques that we have to our armory with regards to microdebrided coablation and also the adjuvant treatment, which I'll go through. When you do perform a tracheostomy, we try and decannulate the patient as soon as possible. And it's a risk-benefit ratio. And if you feel that the papilloma is so fast growing that you can't keep the airway safe, and they're at risk of obstructing, then you get to a point where you'll consider a tracheostomy. Medical treatment, the first one to mention is that of intralesional cidofovir, and that'll be exclusively for patients where there's rapid regrowth, so where you have to debulk them every 3, 4, 5 weeks. Patients where there's distal spread, so clearly have more aggressive disease. There is some concern about malignant transformation, but this has not been fully clarified. And important from a practical point is to inject before debulking. And that is something that I picked up recently, because we traditionally used to debulk the papilloma, remove it all, and then inject afterwards. But it appears that most of the cidophyll will just seep out. So obviously, in a severe case like this, you will have to debulk a little bit, or insert a tube while you inject. Otherwise, with the injection, you'll cause complete airway obstruction. Now, I'll quickly mention systemic Avastin. This is one of the patients I treated who presented very early on. He presented at age 15 months to one of the district general hospitals, and presented late, presented to A&E in extremis airway obstruction. Pediatricians managed to intubate him in A&E, and we debulked him every 3 to 4 weeks. And this is what it would look like after 3 weeks. So very aggressive disease. I initially got approval to inject him with cidofovir and did a cycle of 4 injections, and unfortunately didn't have the desired effect until I discussed with a colleague in London who suggested that they've started at Great Ormond Street, started injecting before debulking. So I did another course of 4 injections, and he had a dramatic response. His last injection was in 2015. And his last MLB was in 2018. And the bottom right picture shows what his larynx looked like at that stage. And so we've moved now from MLB surveillance to clinic surveillance. He's old enough to accept a flexible scope in clinic. And he's not had any regrowth for almost 4 years now. So a really good result. One paper that I came across was a systematic review on the use of systemic Avastin. So this was, they managed to identify 20 patients, a group of pediatric patients and adults ranging from 1 to 43 years. And in this study, all cases showed clinically significant reduction in disease burden, and also reduction in the need for repeated surgery. So it is the problem with RRP is that they're very low numbers. So to try and get a good study to show conclusive evidence that it works is very difficult. So it's usually pooled results or systematic reviews. We will hopefully be able to start using this soon at Addenbrooke's with the help of the paediatric oncologist, which will administer this. Lastly, we move on to prevention. Now, there's no doubt that the future of eradicating this disease will be with regards to HPV vaccination. Initially, when vaccination program was rolled out, it was given Cervarix, but they didn't include the 4 subtypes that we require for RRP control. Currently, only girls are vaccinated, and they're vaccinated using Gardasil, which includes all 4 subtypes, which is good. And if you think about it logically, if boys could be included in the vaccination program, we'd probably get quicker herd immunity, which is what they do in Australia. And this was the paper from Australia where they looked at whether juvenile onset RRP reduced after the implementation of a national HPV vaccination program. So this was a group of pediatric ENT surgeons within Australia. So all the major centers contributed, and they basically reported over a period starting in 2011 whether they've seen a reduction in patients presenting with this. So when they rolled out the vaccination program in Australia in 2007, they also vaccinated all females between the age of 12 and 26 years. They managed to vaccinate at least half of that population, and then started vaccinating 12 to 13-year-old girls through school-based programs. They've then looked at new cases recorded starting in 2011 and managed to report from 2012 onwards. And what it showed is that the rate per 100,000 reduced from 0.16 in 2012 to 0.02. So a nearly statistically significant reduction. So this clearly is where the future lies with regards to control of RRP. So what can we expect for these patients long term? we hope that they will go into remission. They can go into remission at any age, but they're most likely if the disease presented between the age of 6 and 10 years, and if the disease was confined to the larynx. Pulmonary spread is usually fatal, and they either outgrow their lung capacity because they get cavitating lung lesions, or they undergo malignant transformation. This is the chest X-ray of the patient that I discussed earlier. So he presented very early on. He was 18 months old, required 2 to 3 weekly removal of papilloma, and eventually ended up with a tracheotomy. And he was under the care of the surgeons in Great Ormond Street, and when he turned 16 was sent back to Addenbrooke's, and he underwent in total around 80 microlaryngobronchoscopies. He had cavitating lung lesions, these ones identified when he was around 7-8 years old, and they remained stable. But when he transferred onto Addenbrooke's, they compared the new MRI and CT scan and showed that they've changed. So we had a CT biopsy, which confirmed squamous cell carcinoma. Unfortunately, had disease recurrence and went through the whole range of treatment available, and eventually succumbed to the disease when he was 21. His MRI showed big cavitating lesions in his right lung with a fluid level, and this is eventually the area that they biopsied and diagnosed squamous cell carcinoma. And speaking to the respiratory physicians, their opinion is that once this spreads to the lungs, then it is a matter of time before they develop malignant disease. A few controversies within, or anecdotes from my own experience. The first one is mumps vaccine. So there was a paper published in 2002 by a lone practitioner in the US who presented remarkable results. He injected with mumps vaccine and reported 82% remission. So 9 of his 11 patients, they underwent between 1 and 10 injections. During my training in South Africa, we did try this because we didn't have access to cidofovir, and we didn't find any significant benefit, and had significant benefit from using this. Chickenpox is an interesting story. That was when I was doing my first fellowship in New Zealand, and we had a patient that presented again 3-4 weekly for debulking, and then missed one of his appointments. And when we rang the parents, they mentioned that he had chickenpox and he couldn't attend. So we got him back as soon as he got over chickenpox and he wasn't infectious, and his papilloma nearly melted away. There was very little left. So whether the chickenpox primed his immune system and he started attacking it himself, we don't know. I have, in the patient slides that I mentioned earlier, one boy that presented very young, I did ask parents to contact me when he contracted chickenpox, but that didn't have any effect on his disease burden at the time. Cutaneous contact papilloma, this is a colleague, a retired colleague now, that used to deal with a lot of papillomas, and used, in those days, used laser and used it down a microscope. And because he wore glasses, he had to look down the scope with his glasses, down the microscope without his glasses. And the action of putting and taking off his glasses resulted in him having a line of papilloma along his glasses, a line between his eye and his ear. So there's clearly some way that can be contagious. And that's it. Thanks very much.
Hi, everyone. Thanks for making the time this evening, and thanks for having me. And great talk, Nico. It's always exciting when you see the pediatricians show their really lovely videos. I mean, RRP in kids is pretty dramatic, and it's not so much florid in adults. So adult onset recurrent respiratory papillomatosis is the term used to describe RRP in anyone over the age of 12. And incidence in the United States is reported at 1.8 per 100,000. And this is the same figure that's quoted in all current papers. and particularly driven by HPV 6 and 11. Sexual interactions in adults is a big cause for this. It's actually classed as a sexually transmitted infection. And so you can imagine that it's quite difficult when you are telling someone you've got problems with your airway because of sexual interactions. And so it's very important to be tactful in how you deliver that information. Of course, there are the group of pediatric patients who obtained the disease through vertical transmission and then grow up into adulthood. But this is separate from those who develop the disease de novo in adulthood. And typically you do get extralaryngeal spread in the oral cavity, the trachea, etc., the bronchi, and least of all, the esophagus. I'm just going to minimize that. Great. So when you're in clinic, you think about the patient who presents with a hoarse voice, stridor, a chronic cough. You're reading a letter and a respiratory consultant is referring you someone who has a chronic cough, and you're wondering, well, should I or should I not accept that referral? You should be thinking about RRP in that situation. Patients who have unexplained breathlessness, and patients who have recurrent respiratory tract infection. So when you see this patient in clinic, you're thinking of a full history, nasal endoscopy in clinic, and stroboscopy for voice if there's evidence of oh, sorry, can you guys hear me?
I can.
Okay, sorry, I think Siri is trying to sabotage my talk here. This is the problem with technology. Just gonna go back. Oh God. And so the way I've arranged my talk is a sort of almost like hopefully a kind of Viva situation, for example, but an extended Viva situation. So you want to take a vexed nasal endoscopy in clinic. Photo documentation is important if you see something. And you'll come to understand why. Stroboscopy for voice if you're in a voice clinic. And it's quite important to also offer, a kind of functional voice outcome score if you can in adults, especially people who are professionals who use their voice for their work. And it's not unusual, it's not unheard of to come across a professional who really earns their living with their voice, who has recurrent respiratory papillomatosis. And it's quite important to be able to use these functional outcomes in order to give them a realistic day-to-day expectation of where their voice outcomes are. The surgery you want to talk about in this situation is microlaryngoscopy and tracheal bronchoscopy in the theater setting in order to assess them properly and deal with any lesions. And again, you must try and make photo documentation as standard. And you typically take 4 views of photos: a supraglottic view, glottic, subglottic, and down to the trachea where the carina is. People talk about using narrowband imaging, which allows you to see more proliferative lesions that are not necessarily avid to white light. And we recommend taking a biopsy to make sure that you're confirming histological diagnosis, and always ask for HPV subtyping in these patients. Now, the decade severity score is a universally used score, and actually University of Washington have adapted this into an AI program that they use routinely in their in assessing patients. And this is a composite score, which is a sum of a clinical score from a symptomatology point of view and an anatomical score. And the higher the score is, of course, the more severe your problem is. And so you look at the larynx here, and you score for each site whether or not they have 0 for if they have no lesions, 1 if they've got a surface lesion, 2 if they've got a raised lesion, and 3 if they've got a bulky lesion. And you add all of that up, and you add it up to the clinical score for the patient here, and that gives you your total decade score. The aims of treatment is particularly to create an airway and to reduce the tumor burden. And therefore, it's important that when you counsel a patient and you consent, the principles of consent around RRP in adults is to do with empowering the patient and making sure you manage expectations. So you talk to them about their airway, talk to them about tumor burden, you talk to them about their voice outcomes, which impacts on their day-to-day life. You talk to them about the frequency of surgery, which also interferes with their day-to-day lives, their future planning. And also you talked about reducing the spread of disease, because that has an impact on prognosis. And generally, you need to talk to them in context of quality of life. The way treatment should be delivered with an MDT if you can. So ENT doctors, your respiratory colleagues, speech and language therapy is very important for patients who have florid glottic disease, and also psychology. Not everyone is able to manage the fact that, come to terms with the fact that they have a sexually transmitted infection that can cause overwhelming symptoms. And it's important to be able to give these people the help they need. And it's not always available in a lot of centers, but certainly in Addenbrooke's, we have the luxury of being able to get patients to self-refer to a psychologist or plug them into the mental health service. Now, I use a CO2 laser preferentially, and there are two groups of people, or there are two groups of people who will treat papillomas with CO2 lasers in different ways. There are lots of people who would ablate every single thing, and there's a group of people who will ablate and also excise lesions. And I tend to excise where I can. I think it saves time, reduces trauma, but there are certain lesions that lend themselves quite nicely to ablating and vaporizing, and you just have to be conscious about not causing scarring tissue and be thinking all the time about organ preservation, living to fight another day, knowing that just because I take this lesion out doesn't mean it's not going to come back. Do I need to tackle this lesion now? Do I leave it and come back when it's bigger? And those are things you have to be thinking of when you're managing these patients. Also be careful about the anterior commissure and don't be too aggressive, because it's very easy to cause a web, and it's very difficult to manage a web. And once you've caused the web, and that can have huge consequences for voice function. Be caution, as Mr. Jonas already mentioned to you that there's been a study that has shown active viral DNA in the plume. And so you have to make sure that if you are the surgeon in a theater where you're doing RRP, you need to tell everyone about what this is and tell them about the potential for contamination. In my theaters, it's a standard that everyone knows that when we're doing HPV, everyone has a mask and everyone has goggles on as well. In addition to, of course, your laser safety protocols. So the other thing to be aware of laser is that while it's a nice piece of kit to use, it also comes with its own disadvantages. So you think about the risk of fire, the risk, the cost of the laser itself. So not necessarily every facility can afford a laser. In other countries where this disease exists, where they don't necessarily have the access to laser, they use other equipment. And also the skill to use a laser, to have an anesthetist that can jet ventilate your patient, so you have access, or people an anesthetist who can run TIVA, or facility that can afford to buy TIVA, the propofol for TIVA. All of those things has an impact on on what kind of tool you use to manage these patients. So it's not unusual to have some centers here and abroad using cold steel. Microdebrider is very common in kids because of the bulkiness of the disease they have. The KTP laser, which targets more the hemoglobin rather than the water, as compared to a CO2 laser, is used by some people. And Mr. Jonas has already expanded on how hairy some of those procedures can be. Some people even use suction monopolar, and of course you have the pulse dye laser and even radiofrequency ablation. So there are many tools. So the key thing in your exam is to talk about the most common ways of managing these patients. So for example, microdebrider predominantly in kids, and talk about the role of CO2 laser and microdebrider KTP laser in adults. And that should be able to give you the points you need for that particular question. And then Mr. Jonas has already talked to you about adjuvant treatment. And here the indication for adjuvant treatment is in patients with rapid growth with airway obstruction, patients who are attending multiple procedures. So people have talked about more than 4 procedures a year, for example, but you have to make sure that this is, in some situations, will be decided on a case-by-case basis, depending on the comorbidities of the patient. And of course, patients who have distal multi-site dissemination. I mean, the minute you see that, you really need to be speaking about adjuvant treatment. There is evidence already that reflux drives the inflammatory process. So you need to think about anti-reflux therapy in this patient. Mr. Jonas has already mentioned the HPV vaccine, which has really grown and is now a 9-valent vaccine that covers 6, 11, 16, 18, 31, and the others. And of course, and as Mr. Jonas already alluded to, there is already a significant improvement in new cases of juvenile RRP in already, and also in the United Kingdom, in England, started to vaccinate boys now since September last year. So hopefully this will help to improve numbers within the group of patients within the juvenile community, and even in the adult community as well. Now, we've talked about Avastin, and there's, which Mr. Jonas has already mentioned about. The other name for it is bevacizumab, and that these are monoclonal antibodies which are typically used for head and neck cancers and used in other, they're called generally immune checkpoint inhibitors. And pembrolizumab is another one where there's a big study going on, being run out of Mass Gen in Boston, at the clinical trial, which is looking at pembrolizumab in patients who have RP, and their N number is about 22 patients, and they should be rounding up the study in another year or two. And bevacizumab is intralesional, but pembrolizumab is given IV. So a little slightly different, but they're both checkpoint inhibitors. And then, of course, Mr. Jonas has mentioned Stidivir and mitomycin CC, and I've highlighted those two drugs because of the bad press that they've had with regards to being they lead to potential malignancy. And so there isn't so much a great uptake as you would see in the adult population. Some people still use it, but I don't use Stidivir or mitomycin CC at all. Alpha interferon, is something that is a very, very, very good drug, but has a lot of significant side effects. And so it is not used as much as the other drugs, because the other drugs can be given intralesionally. So why would you give someone a systemic drug if you can deliver an intralesional drug? And the other thing, of course, is that alpha interferon comes with side effects such as thrombocytopenia, leukopenia, mental problems. People can be very ill. They can end up in ITU just from the interferon drugs. So you really have to have a good reason to be giving someone alpha interferon. So in general, the patient, you want to empower them with knowledge. You need to tell them what the natural history of the disease is. You have to explain to them that they may require several procedures, and therefore they need to also take some ownership of the disease. If you have patients in the adult population constantly coming to your clinic just for a follow-up, in inverted commas, you won't have space to see anybody else. And so what I tend to tell patients who have been who have had disease for certainly more than a year or two is to give me a call when you feel that there's something, that your exercise tolerance has reduced, when your voice is getting much worse. And then they have more control over their disease. So they get to say when. And to be honest, adult patients are, unlike pediatric patients, as you can imagine, adult patients are a really good judge of how advanced their disease is when they have localized disease. Of course, the caveat is to always look out for extralaryngeal disease in this patient. Manage their expectations. This is a disease that could potentially burn out, but it is not, they could also go on to have it for many, many years. Promote same-day discharge in these patients. Try not to over-medicalize this disease. It's a chronic problem, just like you have diabetes and hypertension. And encourage them joining support groups online, And it just allows them know that they're not alone. It helps to diminish the stigma of having RRP. Sex education is also important. So what do you tell patients? Do you tell patients who have RRP not to have oral sex? That's a conversation I'll be having with Nico in a minute, Mr. Jonas in a minute. So those are the things that you need to be prepared to be asked those questions. And if you're a female surgeon, you're more likely to be asked about the sex part of things than male consultants. So be aware of that. And then, of course, RRP, there's an RRP registry, which is is really an audit tool, which is collating information, and it's being run out of the University of Newcastle. And there's a central database where you put in information about what your patient was like, what the severity of the disease was like, how many interventions they're having, how often are they coming to the hospital, and also what intervention you use. We're using CO2 laser or KTP, and also did you use any adjuvant treatments? What were their response and how have they responded? Now, if you're doing really brilliantly in your Viva, there are a couple of things that could potentially earn you some extra points. So the key thing is to understand the HPV vaccine and understand that there were initial challenges, and Mr. Jonas has alluded to this, about just vaccinating girls. And then finally, there was a lot of campaigning and they decided to vaccinate boys. And then there was this push to retrospectively vaccinate boys. And I think Mr. Jonas will probably tell you a little bit more about that. So that means if you had already passed the age for when you ought to have had your vaccination, are you going to be allowed to be vaccinated, or is that it? Do you not get a vaccination just because you're 15 and you've missed that 12, 13 boat? So there's some discussions to understand about that. Know about the fact that there's this AIR registry. I mean, that's a really nice thing to drop in there. Shows that you're aware of current challenges. And there are a few studies that are going on, which is in RRP, that are using this criteria called RECIST, which is a response evaluation criteria in solid tumors. This is actually typically used for malignant tumors, but a few, certainly the Keytruda study is using RECIST in order to, as a way of grading whether or not there's response to Keytruda or not. It's a very absolute way, a very black and white way of determining whether a lesion is responding to a treatment. And so those are just a couple of things that could earn you some extra points during your Vivas. So this is my surgical setup. I'm a little OCD. Anyone that knows me knows I have a little bit of OCD, but the benefit of this, I mean, and I don't, and apologies to anyone who feels that it's a term that I shouldn't be using. OCD is a real thing. But what I mean is that I'm very particular about how things are. So can you see the red line on the floor? You've got my microscope in the corner. My microscope always sits there, and everything is like this all the time. That's one of our registrars, Alfred, and Alfred is going to do this case. That's my chair, which is called the throne. I love that chair. Anyway, and that's the scrub nurse. And in the theaters with the Airway, the scrub nurse really does a lot of work. Everyone here knows each other, and you can see the stack behind, no wonky screens. That is a big deal, but it is a big deal to me. And of course, you've got the microscope. And you notice we haven't completely draped the microscope. It just gets wiped down. But everyone wears masks and everyone wears visors. And even before COVID, everyone will still be wearing a mask and a visor. And this is another view, so you can see there, and you can just about see the laser in the back there. And because I set up like this all the time, every single case is set up the same way. So it diminishes the risk of errors or mistake. It's very easy to teach because the registrar can set up the same way all the time. And the anesthetist is there. He's running TIVA, and we're going to jet ventilate this patient with a hand-sucker subglottic jet. Now, the lady who was on the table, her name, she's a lovely lady. She is now 51, and this is her voice now. did you all hear that?
I'm not sure that played through, Miss Irene. Could you try it once more, please?
All right, okay. I will just, maybe I'll take my pods out because it might have been playing just to me. Okay. I will try and play it without my pods, and let's try again. Hold on, let's go back. I think it might have just been playing to me.
A, B, C, D, E, F, G, H. My favourite food is salmon, and I enjoy long walks with my family.
All right, did you hear that?
Yeah, that was clear.
Yeah? Okay.
Yeah.
Great. So you heard that, yeah? Good. Okay. So, so this is her November 2009, and I just did the left side, and I just used the laser, and and you try to preserve that lamina. But she's been having procedures even before I started at Addenbrooke's, and you can see her disease. It's not so bad. I mean, this was I started doing her procedures in 2016, and this is 3 years on, and you can see the volume of the disease is not that much. But when I first started doing her, and I had some images, but this document was just, the talk was getting too long, so I didn't put too many more. So November 2019, and this is her December 2019. And sorry that the video starts from here, but this is just, so this is the hand sucker jet jet there. We're jet ventilating the patient. And so she's got no tracheal disease. Subglottis is fine. And this is what she looks like. So, not a great view, but when you actually look closely, there's not much to do really for her. So and that's in a year. I mean, between this time she had already had 2 other procedures. So actually between November 2019 and December 2020, she had had a total of 3 procedures. So not very exciting talk there, I'm afraid, but happy to take some questions.
Oh, thank you so much, Ms. Irene. And I disagree. I thought that was really interesting, and what a lovely holistic approach you gave us to thinking about RRP. I think that's something you don't get from the textbooks, and is one of the big benefits of this. So thank you so much. I appreciate we've only got a few minutes before 8 o'clock. Are you both happy just to go a little bit beyond 8? Because we've got a few questions that have come through, if that's all right with you both.
Yeah, sure.
Yeah, fine, no problem.
Thank you. So one of the questions we had was about the role of flexible bronchoscopies, probably in both adults and children. But if there is distal disease, is there any role for flexible? Can they do anything with the flexible bronchoscopies for surgical or interventional clearance for these patients?
I don't think really there's a role in pediatrics. If you examine up to the carina and down the left and right main bronchus, and that's disease-free, and the patient has an X-ray, I would say probably every 2 years for aggressive disease. Mm-hmm. If you do more regular surveillance, then an MRI is probably better to reduce the radiation risk. But I'm not aware of any benefit. I think you can assume that if a patient's gonna develop pulmonary disease, they'll have tracheal disease first. So you'll pick that up when you do surveillance. Okay,
great, thank you. And in terms of,
I was going to say for adults, there have been times when you've had a solitary lesion, and I've had a colleague who was able to do a flexibronch on a patient, and just use a snare to take the lesion out. And these days our respiratory colleagues, they can do all sorts. They can actually also inject the lesion on the flexibronch. The truth of the matter is that it is easier to just do a joint procedure on general anesthetic. But if you don't have the room, the capacity, and you're sharing this patient with your respiratory colleagues, it's pretty a neat way to get them sorted out.
Great. we had another question about the pediatric to adult changeover. So is it possible that a child goes into remission and the disease disappears, but then it recurs as an adult? Or if that was to happen, would you treat it as a de novo disease process in the adult? Does it change the management in any way, your management options, if that was to happen in an adult?
Fortunately, I would say, only have experience of one patient that, and he appeared, this is a patient that passed away when he was 21. So he was never disease-free. He looked like he was going to go into remission as a teenager, but he still required, at that point, 6 monthly MLBs, and he had small residual lesion on his one cord and a little bit of disease in his subglottis. And we knew that he had pulmonary disease, which was picked up early on. So I think if there's pulmonary disease, they need lifelong surveillance. If they appear to be going into remission clinically, there's no evidence of any laryngeal tracheal disease with a normal cross-sectional chest imaging. I think I'm not sure. I would assume that you'll still keep them under surveillance, but less frequent.
Okay. Fine. We then had a question about extralaryngeal disease. This is, I think, more for you, Ms. Irune. Your experience of adults who develop extralaryngeal disease, and they're particularly asking around maybe sites that we hadn't considered before, oral cavity or the esophagus. I guess who else does get involved? Does that then involve max or upper GI? Can you still use the same treatment? Have you got any experience of or advice about that?
Yeah, so you very commonly, I mean, you get ENT can treat any of those things depending on how high the lesion is. So absolutely, and even if you need anybody else at all to come in with you, you may need your upper GI colleague to come in. But typically, this is stuff that we ought to be able to handle ourselves. So we don't. I've not seen disease in the esophagus that's so florid. I mean, that is sort of like developing country kind of disease, and I don't have experience of that. And I mean, if you have it, and remember that the esophagus is one of the least common areas for extralaryngeal spread. So if you have a huge burden of disease, then you have to be looking elsewhere as well, in the thorax and etc. And maybe looking for, does this patient have any other thing like HIV, etc. And so yeah,
that's a really good point. Thank you. We've got a couple of practical questions about treatment options. There's a question here, Mr. Jonas, about using coblation in the pediatric cases, and there's a question about the fluid that you need for the plasma field for coblation. How do you manage that in the airway if you are using coblation to treat the papilloma?
I've only used coblation on one occasion, and I didn't. I was uncomfortable because of the stimulation it causes and sudden jerky movement of the vocal cord. So if you're going to use that, the patient should usually be paralyzed. We don't like jetting pediatric patients, so usually rely on them breathing spontaneously. I suppose theoretically there'll be concern that if you're going to ablate papilloma and you're using saline as a conductive medium, that some of that can run down the airway and spread papilloma down the airway. So I would say to have the patient head down quite significantly, the table quite high up. So if that all saline that you use that doesn't go up the sucker comes into the pharynx rather than going down the trachea.
Yes, when we often only use a subglottic jet if we need to jet. We tend not to, for HPV, routinely use a supraglottic jet, and that's absolutely right, and for the same reasons as well.
Great, thank you. And a question here about a little bit of clarification about I was going to say quadrivalent, but now the multivalent Gardasil or the vaccinations. Is there any role for the vaccination as I don't know if I should call it treatment, but there's a question about if somebody, child or adult, has already had exposure or already has disease, is there still a role for using these the new products, the Gardasil or whichever variant vaccination?
Nico, do you want to go first?
Yeah, I don't have any experience. We do advocate it if we pick up,
Mm.
and I think it's not, I don't think it's recommended in, I can't remember the age group, it's 7, I think, and under 7s,
Okay.
as far as I'm aware. Yeah.
In adults, there is evidence that suggests that it increases the intervals between procedures, but these are groups of small numbers.
Okay.
So actually, in reality, you know, if you've got a patient who's been coming to you for ages, there's nothing to lose.
Yeah.
And so you just tell them, listen, get your GP. And you have some GPs who say, I'm happy to do it, but sometimes we get letters back that say, well, I don't even know where to start with this. And, you know, because the vaccination is expensive. I don't even know where to start with it. Or, you know, do we have approval for this, etc. And so when I have a discussion about the merits of vaccination with patients, I'm very, very pragmatic. And I say, listen, we don't have solid evidence for this. Otherwise, it will be standard of care. But if you've got nothing to lose, and they're really, really keen to try anything.
Yeah, that's a really important thing that I hadn't really thought about. Is also, you mentioned about patient education as part of the journey of the management, but actually sometimes it's clinician education that can be almost equally important in the process.
Yeah, absolutely.
We've also got, I hadn't really thought about this, but we've got a question about radiotherapy. HPV-driven cancer responds so well to radiotherapy in the oropharynx. Is there anything to suggest there may be a role for radiotherapy for very, very florid or very difficult to treat RRP?
Wow.
No.
Oh, no, I didn't say no. I said
wow.
Okay, wow. I mean, there are so many in where we are now, in a regional center like Addenbrooke's, in a developed country like the United Kingdom, etc. It's a pretty rough thing to do, and also don't forget that if you're talking about the progress of disease to the point that you're having to think about radiotherapy, it means that this patient has disseminated disease and florid disease. So what are you going to irradiate? Also, radiotherapy does not work where you have florid disseminated disease. Systemic agents work better in that situation. And so I don't have any experience of that. And I don't see myself getting to a situation where I'm asking or advocating for a patient to have radiotherapy. I mean,
I feel like the treatment burden might be quite large in adults and in children. I can't imagine that it would be something, but it was an interesting question, I suppose.
I mean, Nico, do you have any experience of this?
I don't, and I'm not sure whether the patient I had that passed away had radiotherapy. I can't remember. He had everything else. He had photodynamic therapy, and he had joined various trials and had various chemo regimes. Because he was so young and fit and healthy, they threw everything at him. So I think they would have been reluctant to irradiate. I'm not sure. I'll have to look into that, because he was, after his pneumonectomy, they realized he had mediastinal disease. So, and that's when they tried all adjuvant therapies available.
It's just a reminder of how I think that the textbook kind of thing, you come back with RRP, so RRP in children, it goes into remission. But actually your case is a real reminder of how we should be taking this, you know, you can't be dismissive of the disease process at all in children. One last question was about cidofovir injections. This concept of injecting before you microdebide. I don't know if that's the same also in adult care, Ms. Irune, but they were asking about where do you inject? Are you aiming to inject the actual lesion, or do you have to inject the mucosa sort of in the cords beyond the lesion?
Sorry, this was only anecdotal, and this was based on that one case that was quite aggressive. I mean, I've only used cidofovir in 3 patients. Now we'll be able to use it because we've got it on formulary at Addenbrooke's, thanks to Jess, who put in the hard work to get it approved. But you try and inject it as widely as possible. I mean, we have 2 mils to inject, and you obviously will start off targeting the areas that are mostly affected, and you do make the airway worse initially. So you put a small tube in, inject as much as you can, wait, and then microdebride, because previously, when you microderide first and then inject, you just see it oozing out, so you're not sure how much effect it has locally.
Thank you, Jonas. Anything to add, Ms. Irune, on Pseudophobia?
No.
Okay. I have
just that I've known some people who use it, who, when it first came out, I just remember some people, one of my trainers using it topically, and I just thought, yeah, all right. But I think times have moved on, and
yeah.
you know, what Mr. Jonas describes is typically how it ought to be used. It's to be used intralesionally and properly. Yeah.
Fine. Somebody's asked probably more targeted at the content of your talk, Ms. Irune, but about can you advise? Is there anything you would say about reducing the risk of transmission in terms of sexual practice? Yeah. Would you go into that conversation, or is there a?
Yeah, of course, absolutely. I think you know, if you're going to talk to these patients, you know, when you get to know the patient as well, you know, you start to have these conversations. We have these conversations where we have HPV related oropharyngeal carcinoma, so it's quite natural to talk about these things. And so the evidence is that the association of RRP in adults is more common in patients who have had multiple sexual partners. So that's one of the associations that in adults, you cannot necessarily draw always a line from sexual interaction, i.e. meaning oral sex, to recurrent respiratory RRP, or, you know, but in general, we know that HPV is a sexually transmitted infection that happens from contact, in particular genital contact. So that is those are the kind of impression and deductions that have been made, and there have been case reports of some patients and also papers that have been published about people who have, where you can say this was a single event that led to me developing RRP. So the key thing is just to be pragmatic and to say, listen, you try and have fewer sexual partners. Make sure your sexual partners are aware of what you have. Decide whether or not you're going to use a condom or barrier when you're having, or femidom or whatever, or when you're having sexual intercourse. And even with oral sex, you can talk about whether or not they want to use a condom, and you can plug them into self-help groups, etc. So these are the kind, but what you don't say to someone is stop having sex. I mean, life is cruel enough. You can't do that to them.
I think it's different. There's such a feeling of judgment or fear of judgment that even patients will feel inhibited to ask for the advice. So I think that's really useful to have that kind of openness there. I think just as we're approaching 10 past, I'm going to ask just one last question that we've had, which is about voice change, really nicely covered by Ms. Irune about quality of life impact and assessment in adults. But in terms of the pediatric patients that have been treated for RRP, do they tend to go on to develop normal voice, or is there anything that people should be more concerned about monitoring or assessing in terms of long-term voice changes for children?
I have no doubt that they will have long-term effect. I mean, even though the aim is to restore, keep normal anatomy and only address the disease, it's often so florid that it's very difficult to make the distinction between papilloma, scar tissue, normal laryngeal anatomy. So I think they do end up being patients for life. I mean, in pediatrics, we really focus mainly on the disease control, airway control, and then when they're old enough to feed into a voice clinic and tolerate stroboscopy, then we'll do that. But in the early stages, we focus mainly on maintaining the airway and keeping them safe. And it can be quite a battle in the really aggressive early presenters. I mean, you nearly, certainly if you're a single-handed surgeon, you plan your holidays around your RRP patients to make sure they don't run into trouble when you're away.
Wow,
that's why you should do peds. And work in a big center. There's no sleep for you. Just kidding. It's a great specialty.
That's a really key message to end on, I think, for all the trainees listening. A little bit of advertising. I want to thank you both. Yeah, definitely. I thank you both for your time, and thank you so much for such great talks and really great approach to the condition and giving us a really nice pan overview. But I think probably the conversation at the end of the discussion, the question points, really helpful. There's quite a lot